So we have reached 9:30 on this a bit grey Friday, at least here in Aalborg where I'm sitting. My name is Jakob Braun and I'm the CEO of Access to Innovation, and it's my honor once again to open this edition of our Access to Innovation talk, or in short A2i talk, where we today have a focus on the effects on the COVID-19 situation in Eastern Africa, or at Africa especially. As some of you know, Access to Innovation, we're the Danish innovation platform where we are bringing together civil society, private sector, academia, investors, and government institutions together in joint efforts to create the needed sustainable solutions that are required and asked for, together with our partners in the African continent. Been in operation now since 2007 and created more than 80 partnerships over the years. And one of the findings that we've seen from the Access to Innovation Network is that there's dire need also from learning from across the different sectors and institutions, organizations being part of the Access to Innovation Network. So today we have invited Flemming Konradsen, professor at Copenhagen University, for sharing some insights within the situations that we're now facing and the effects that we are facing with the COVID-19 situation, especially in Eastern Africa. I think it's all of course great concern to all of us. We've seen the effects in Europe and recently in India. But this morning when I was looking at the map from Johns Hopkins, I would actually prefer going to Africa, as the situation doesn't seem to be that fierce and effectful as we see at the other places around the world. So for sure there's effects of the COVID-19, but what we also learned probably from today is also the associated effects of it both open some challenges to the continent, but in the perspective of our innovation focus and our partnership focus also requires that we are stepping up as a partnership and working intensively across to solve some of the solutions that we are facing. So I'm quite honored to have Professor Flemming Konradsen with us today. He's been in the game, so to speak, for more than 20 years and is together the manager of the School of Global Health at Copenhagen University. And he's got more than 20 years of experience within global health and has been working with a number of international recognized research institutions, NGOs, and of course at the universities and private sector. The format, as we have been testing out the last few times, is pretty simple. We've invited Flemming to give his view and some insights for the next coming 20-25 minutes. And following to that, there's an open part for questions and Q&A, following up on the questions of the presentation from Flemming. We will. I'll do my best to navigate in the Q&A session. And I invite you to use the chat bot as a part of this Zoom call, where you can put in your questions and I'll try to direct you and invite each and one of you, for those having interest in coming up with a question, to jump on board. Further on, we are taking the liberty of recording this session and sharing with the other interested parties that haven't been able to be here today. So it will also be publicly available and you're free to share it following for those who have interest in that. So without any further ado, Flemming Konradsen, thank you again for joining in, and the floor is yours.
The host is muting me, I can see. No, now I'm ready to go. Thank you so much for the invitation and nice to meet the group. So I will very briefly touch upon the status in continent-wide in Africa in terms of COVID. And then, as you also pointed out, Jacob, look at some of the direct and indirect impacts, and then a few additional, let's say, trends, or looking over the coming year to 5 years, what may be the needs and requirements for partnerships to address in an African context. So first of all, as you also pointed out, Jacob, when we look at a map and we see the daily updates from whatever organization, we are looking at data from Africa does not seem in broad terms to have been, directly impacted so severely by the COVID-19 pandemic as we had feared, and also as we have seen in Western Europe, North America, and certain parts of Asia. I often get the question why that is. Why is it Africa has not been impacted to the same extent? The short answer is we just don't know. Of course, we know something, and we know the data is likely to be incomplete, especially case information. So when you see cases with the current testing capacity, with the access, diverse or differences in access to testing across the region, certainly the case numbers will be very, very incomplete. But also mortality figures are likely to be incomplete. But I think it's fair to say that the conclusion still holds that Africa has not been hit as hard as, for example, Europe. I think the reason why this is, as I'm sure you could guess, demographic profile. We know that certainly if we are looking at severe disease and mortality, age plays a role. So if we are looking at the first region hit very severely in Europe, in northern Italy, approximately 28% were above the age of 65. In many African countries, that would be 4%. So a huge difference in demographic profile. We also see that there's quite a difference in the level of what we call comorbidities, underlying risk factors for severe COVID-19. So if you have a population with significant cardiovascular disease, diabetes, and so on, they're at much greater risk. That, of course, has also come big time into Africa, but still at another prevalence than many North American, European populations. We also see that in 41% of death in Europe has been from people living in nursing homes or senior residency. That, of course, is much less widespread in Africa. We also see that there's more and more theories supporting the idea that a population that have been exposed to a history of infectious diseases over even generations are better prepared or respond disease that hits the population. So you could argue that past coronaviruses, dengue, malaria, you name it, infectious diseases may to some extent have protected the populations in parts of Asia, Latin America, and Africa. But you could come with a very, very long list. The short answer is still, we don't know why Africa apparently has not been hit at the same extent as North America or Europe. And since we don't know this, I think it's also fair to say that how the pandemic may unfold is uncertain. If we all had met some months back, January, February, talking about India, I don't think, honestly, we would have foreseen what is now taking place in India. So the introduction of new variants, new types of this new coronavirus is likely to change the picture. There can be a silent spread, asymptomatic as we call it, spread of infection in the population that may then all of a sudden emerge into a major, let's say, fuel to the pandemic. So I think it's fair to say that it's uncertain and we have to prepare for uncertainty on the African continent in the month and even the coming 1 to 2 years. We cannot be certain yet. But the direct impacts have been more modest. But the indirect impacts have certainly been more severe in Africa as compared with, for example, the Scandinavian setting. So the indirect impacts we know from epidemics in the past, and also, of course, we don't have so many pandemics, but also pandemics in the past, that the indirect impacts of an epidemic is likely to be much much greater than the direct impacts of an epidemic. We know it from Ebola, we know it from dengue, chikungunya, so on and so forth, measles outbreaks. And the indirect here in an African context has been quite significant. That has related to the care for chronic treatment. It has been a whole range of preventive measures that are put on hold. We see a reduction in family planning activities. We see a reduction in immunization coverage, child nutrition and feeding activities, break in care for people living with chronic illness, mental health support have been reduced. So the indirect implications are likely to be very significant. And either the next ring outside the more direct, let's say, health-related indirect impacts, we obviously also see in the next tier indirect impacts in terms of economics, in lost school days, in terms of loss of employment, in terms of reduced investments, and certainly also elements that relate to logistics of food production, distribution, and investments. So you could keep drawing circles from the pandemic or local epidemics and see the impacts it has on health services and much broader on society. And that, of course, is also where we'll see the need for investments in the years to come to catch up, try to reduce the negative impacts of these indirect consequences of the pandemic. Often people would also ask me, so hasn't it been wrong to focus so much on the pandemic? Wouldn't it now be time to say COVID-19 hasn't really hit very hard in Africa? Let's focus on the other major health problems. I can see the point, and to some extent I agree. The problem is that we cannot avoid investing in pandemic control activities. Because, as mentioned, if the pandemic, like we know from local epidemics, if it unfolds, will continuously have other implications, will continue to have negative implications on a whole range of other health outcomes and societal impact. So it would be a major gamble to say, so far it has gone well. Let's go back and focus on the much needed diarrheal control, malaria control, diabetes control, and of course, nutrition, economic development. But it goes hand in hand, and it is incredibly difficult to say, we'll forget about the pandemic and just focus on the classical, where we also need investment. That I would not recommend. We simply have to focus on vaccine rollout. We have to focus on strengthening the healthcare services for COVID-19, but also for other health outcomes. We have to keep investing in building a stronger, more robust, responsive healthcare system. Anyway, that was a little bit on, I'll check my clock if you excuse me. I still have some minutes. So what I also just wanted to touch upon was a bit of the wider issues. We have seen some countries reducing their direct aid. Of course, the G20, also G7, in recent meetings have come forward and put a hold on some of the, let's say, the repayments, the national payments into debt relief and other issues. But the aid in some Western European countries, we have seen major from the UK have reducing the classical aid, and because the money is needed in our own government budgets. And that, of course, would have significant implications for direct aid into a number of African countries. And that's something I think we should all argue against. The need for support for the healthcare, the agricultural, the social, the educational sectors in Africa obviously has not gone down during this pandemic. So it doesn't seem politically a sound argument to say we need the money back in our own state investments in our own countries. But that's what I fear might happen. We also see a lot of geopolitics unraveling in a number of African countries. Certainly the Chinese investment authorities, a few Middle Eastern. We also see an active engagement from some of the investors in, for example, Russia and some of the Asian investors, linked sometimes with the vaccine policy, sometimes linked with opportunities, and sometimes simply stepping in where Western countries are not up to the task. So we might also see some geopolitical changes in terms of investment climates, in terms of stakeholder relations being strengthened with new actors moving in. So I see the vaccine, but also testing, also protective equipment. China are investing massively now in supporting healthcare in a number of African countries, also on drug support and discovery even. So we see a new role for international actors. We also have seen, when we read about some of the capacity development activities, we see now a number of studies coming out looking at how traditional aid has been turned upside down. More responsibility has been given to in-country partners, new ways of using technology, new ways of managing project, allocation of responsibility. All of those, you could say, are very sound and needed developments. Maybe we have jumped several years ahead in terms of building future, more fair, reasonable collaboration. So technologies have certainly changed significantly over the past year and a half. New forms of partnerships are emerging, and not just new partners, but forms of partnerships have certainly come up. We see in South Africa, we also see it in Nigeria, in Egypt, Ethiopia, new interest in building local production into the healthcare. For example, personal protective equipment. We see it also, they've been hit very hard in supply chains. And like we discussed, wouldn't we need a more robust locally supply source? That is also becoming a major political issue. African Union is taking this up big time. So we also see that emerging. Then, I've spoken too long maybe already, but just one issue that—
Please go ahead. Please go ahead.
Yeah, just one issue that was kind of in the title, and people around this particular Zoom are certainly as aware as I am, so I'm sure you have more to contribute with. But looking at our own activities in Africa from a research and capacity building efforts, I think looking at the way we have to deal with projects on the ground is back to this uncertainty. I would love to be able to tell you how it's going to look like in the month to come in terms of the disease manifestations, but logistically, in terms of insurance, in terms of transport, in terms of uncertainties in testing capacity, national from one of the African countries or someone flying in, there's just a lot of uncertainty linked to your implementation. Like as we speak, we have people stuck in Qatar and in Dubai who cannot leave the airports because they were not able to be tested correctly upon leaving some of our African partner countries in the airport. The testing capacity was not up to standards, and they have now been rejected based on their test and cannot enter an airplane. We see that overnight scheduled air departures are changing. We see lots of uncertainty. So a lot of logistical liabilities linked with project implementation. So that we also, of course, need to take into consideration. And lots of you around the call have local strong presence, and of course, like our university partners, it would be different. But uncertainty for the foreseeable future is part of how we have to operate. That was some of the thinking. I would love to get questions instead of talking more. Thank you.
Thank you so much, Flemming, and also for the range of observation. Now the chat is open, so please feel free to jump in with questions. I got one just to get going. Of course, we see now the effects from the COVID-19 situation, but it's not the first time that we see Africa being hit of not pandemics, but at least epidemics. There was Ebola a few years back, as far as the similar diseases spreading out in Eastern Africa. Are there any lessons learned from there that we can bring on?
Yeah, and certainly we have seen a phenomenal capacity and learning. We have seen, as you refer to, at least the West African Ebola outbreak. So the tracing of cases, the communication efforts, the primary healthcare community type healthcare services have actually been much better equipped than many European countries. We are very dependent upon technology and infrastructure, and very much borne by our, let's say, healthcare professional being bound to clinical facilities. So we see that a number of African countries who have a much stronger tradition for community engagement, local health professionals or even volunteers have been phenomenal in communication, in outreach, in contact tracing, and so on and so forth. So actually a mixture of some of the systems we see in Europe with some of the systems we see in Africa would make us better prepared. So there's a ton we can learn from healthcare management traditionally during epidemics in Africa.
Okay, thank you. Now see there's a question coming from Peter Thorning, the Danish Refugee Council. Peter, it might be that I could invite you to ask the question directly.
Thank you very much. Can you all hear me?
We can.
Thanks a lot, Flemming. And what I've written in the chat there is that you're probably aware of this debate about the vaccine patents that's ongoing, and with South Africa and India wanting to build capacity for their own production. And as we know, that doesn't solve the problems here and now. But what's your view on this debate? And is there any way we can compare this to the situation of antiretroviral, what was it called, the ARV situation in relation to HIV/AIDS some 20 years ago?
Yes, I think it's a much needed debate in terms of, and now we have, of course, a very significant number of countries backing the Indian South African initiative. So yes, it's a needed debate, and it's a broader debate in terms of actually establishing production in major African metropoles, and also getting a discussion on cost of medicine and so on and so forth. It in itself will not do much difference in terms of getting vaccines into the arms of people in Africa the coming year, 2 or even 3 years. So it's a little more of an ideological, but I respect and needed debate. We don't have the production infrastructure at the moment. We can't turn away from the fact that Canada today are receiving 600 to 800,000 vaccines directly from the COVAX initiative, vaccines that should have gone into the arms of Africans. We cannot avoid the discussion that here in Copenhagen, we have several hundred doses on storage. We are compiling doses across Europe, hundreds of thousands, even millions. And honestly, at this given point in time, we need to redistribute. We need upfront across Europe to say 5, 10, or 15% of the forward deliveries of doses are not entering France or Denmark, they're entering directly into the COVAX initiative, to the healthcare professionals, to frontline workers. So I respect the needed debate. It's just not going to solve the problem here and now. It's another political debate that we are not going to discuss immunizing boys and girls aged 13 and 14 in Denmark, which is now being pushed through our own parliament. It's silly. It's crazy. Sorry for being straightforward.
Thank you.
Thank you, Flemming. I think once in a while we need straightforward talking, so that's fine at this call at least. I see also there's a question now coming from Islandi. Is it Stefan Islandi? Perhaps you would jump on the call.
Yeah, thank you, Jakob, and thank you, Flemming, for a very interesting initial talk. I have a few questions. You mentioned a very long list of indirect impacts on the African continent. Could you tell us where would you put your initial investment? Where should we, as donor countries, put our initial investments? Have you got any views on that? And then before you get into this, a few more questions. It's one, you're talking a lot about what we as donors or what the West could have done differently and what we ought to do, and I tend to agree with you. But could you tell us about how do you find that the African governments, I know heavily generalizing, have coped with the pandemic so far? I mean, I know there's a huge difference between Tanzania not recognizing the COVID at all, and South Africa, but maybe a few words on that. And then finally, could you imagine that anything good could come from this in an African context, especially related to the health systems? Because from an NCD point of view, which is my main interest, I could actually imagine that something good would come of it. Now we recognize that these are the most vulnerable people, and maybe that should be taken into account going forward. Thank you.
Yeah, I'll do my best. I hope I got them all. So where I would put my investments, I'm probably biased, and I don't think anyone would have, let's say, the answer to this. And certainly as a collective group around this call, you would be better informed. But seen from my perspective, I would certainly find it necessary to invest more in preventive health services and also catching up in, for example, immunization, family planning activities. And we know now for sure that building much more hygienic health facilities, there's a lot of spread of disease at poorly managed, maintained health infrastructure. It's quite depressing to see how antibiotic strains, how infections are spreading in healthcare facilities. That's from a sanitation, water, hygiene perspective, waste management, top of the list of something we have to do. But obviously, we have really many unfortunate unwanted pregnancies because our family planning is not rolling out. Same for immunization. So I would strengthen the healthcare services broadly. And taking one of your later questions, it's time to integrate non-communicable diseases with infectious diseases. They are inseparable. There are so many reasons why we have to look at health promotion, because nutrition plays a role, the diabetes, tuberculosis, you name it. We have to get away from disease-specific programs to a greater extent. Not totally, but we need to look at the comprehensive universal primary healthcare approach that has been so successful in a number of countries. So that would be, from a health perspective, my priorities. I fully accept that employment, food production, agricultural support systems, and as well the educational sector, we might lose, I don't know if you call it an educational generation or two. So we cannot afford it. So catching up on education clearly also. But others, I'm sure, would have other good points. In terms of the governments, performance. The governments responded incredibly quick, faster than maybe anyone else around the world in closing down their countries. So African countries responded even before having established cases. That has been highly criticized. Did they close too firm before it was even a problem, creating lots and lots of poverty and impacts that could have been avoided? I don't think they could have done any different, to be honest. And that might also have prevented the spread of infection. As you pointed out, it would be too long to discuss national specific in terms of responses. Yes, Ghana has done very, very different compared to Tanzania. So maybe that would be too broad and, let's say, a discussion to have around this soon. I think that was at least attempting to respond to the questions.
Thank you so much. And I can see Ulla, and now I've been trying to resume. Is it Tawaya? Sorry, Ulla. Perhaps you could pose your question. Thank you.
Thank you. Flemming, 2 questions actually, and thank you very much for this very, very interesting presentation first. Many have said, yes, the testing is not widespread in Africa, but one way of measuring whether it's grave or not is if there was a spike in death rates. So one of my questions is, has there been any spike in death rates at all, even minimal, or is it just sort of same as always during the pandemic? And the second question is, I've read in a few public media outlets that there has been a study that the Asian population might be more prone to getting the corona, and I don't know if these studies have been confirmed, but my question is actually, has there been any studies about the African population in that respect?
Yeah, so first, the excess mortality, as we call it, we have, as some of you may even be involved with, they're called the in-depth network. So they have a number of demographic and health surveillance sites across Africa. They are one of our best sources to look at excess mortality. South Africa, yes, it has been quite significant. In other places, we have not seen excess mortality. So there's something in northern African region, so parts of Egypt, we have seen excess mortality. And as I just mentioned, in Mozambique and South Africa, but there are many other places where we haven't seen it. And I know one on the call is from Sudan. We haven't seen, at least not registered, excess mortality of any significance. We fear, so the first excess mortality figures are coming out. Actually, it came out last week from a range of institutions linked with the African Centers for Disease Control. And now, unfortunately, we start seeing increased maternal mortality. We see child immunization, lack of it starting to kick in. We see lack of access to care setting in on disabilities. So it's a little difficult to separate the direct from the indirect. So we do see also on nutrition significant fall in nutritional standards. So whether or not it's all, if we cannot control the pandemic, but also the cost of controlling the epidemic or pandemic, of course, has implications. So directly to your question, excess mortality is probably something, unfortunately, we'll start to see from now onwards. Anyway, on your last point, we see there's studies out on blood type. There's some indication that prevalent blood types in a number of African populations are protective. But we are talking about a protective effect of 15 to 20%, which of course is not insignificant, but it's probably not explaining the entirety. But overall, I get from your 2 questions, and I would agree with you, the immediate direct excess mortality and mortality figures in Africa from COVID-19 are less and much less than what we have seen in Brazil, Europe, North America. They are, but unfortunately, we now see the indirect impacts.
Thank you for that. A bit the same line as I can see here from Aleri. If you would like to jump in with your question, please. Otherwise, we'll move on to, otherwise I can of course read it up loudly and clear. In regards to your point on the possibility that Africa has had a larger population exposure to other infectious diseases, which could be seen as the factor contributing to the lack of very large numbers, what health issues do you see rising in numbers, seeing as all in factors indirectly affecting Africa, as it's already being felt?
So I think I understand the question. So there's some of them that are these indirect, as I mentioned to Ulla before, which we are fearing. So the access, we have seen documents now that healthcare workers were afraid of showing up to work because they didn't have sufficient protective equipment. They have not been immunized. And also some have been infected and some have had to turn to isolation. So there's no doubt both the, let's say, the demand for service and the delivery of service have been impacted. And that we now see on follow-up to diabetes care is being impacted. The International Diabetes Federation have come out with these data. We see same for hypertension monitoring and so on. So a broad range of health outcomes that this healthcare service normally deals with simply have not have been on pause. We see it also in Denmark. We saw it last summer. In Denmark, we can just say, well, we'll allocate another few billion Danish crowns to the healthcare service in catching up. And then we recruit a few hundred doctors and nurses, at least 400 or 500 from Eastern Europe, take them away from their healthcare service. We invest in Denmark, and we have pretty much reduced the waiting list for a number of critical care services in Denmark because we can invest and we can attract healthcare workers from our neighboring countries, stealing them from someone else. But that's not an option in many African countries. It will take much longer to catch up. We are short 3 to 5 million healthcare workers in Africa. So catching up is not an option. Money-wise, infrastructure, human resources. So it's a world apart. So the implications, long-term implications, will be longer lasting in many African healthcare systems, in spite the fact that the direct impacts of COVID-19 has been less. Anyway, that may or may not have answered the question.
But it perhaps leads a bit to the another question here from Jairo Munivi. Perhaps should I just read it out loudly, or Jairo, are you on? At least what is asked in terms of the Danish and international NGOs also raising awareness here among the Danes. When operating in Africa, implementing projects, have they been fit for purpose? What are your views on that? And perhaps we can ask, if they haven't been fit, I mean, what are the potential for the NGOs and perhaps also working with government, academia, and private sector in building up the capacity?
Capacity, you're thinking within healthcare or broader?
That is probably directed in terms of the COVID-19 here. So the overall questions, if the Danish NGOs have been fit for purpose in terms of meeting the demands on the ground. And then I'm adding on the question whether there should be, what's the potential for looking forward?
Yeah, I of course don't have the overview, but I've seen lots of examples of Danish NGOs and not least their partners being adaptive, being ready to take on a new challenge. Diverting maybe from their set regimen and do something new that's needed right now, the flexibility. And Ulla was there before from the Danida Fellowship Center. I also know a number of the Danida supported research projects, and I'm sure some of yours as well, Jacob, have shown enormous flexibility. because that was needed. And I think that that is certainly a strength. We just, of course, have to make sure we harvest the good experiences from that involvement. And when it comes to the healthcare sector, we have to find new ways of training hundreds of thousands of healthcare workers. We have to find new ways of communicating preventive messages. We have to deal with the infrastructural challenges and technology challenges. And we do that much better actually in some of the new forms of partnerships that have been established. I see large Danish companies have now stepped up to the task, the challenge, and reached out to community organizations. So I also think some of the Danish large companies have seen the need for, they have never been in healthcare before, but it has opened their eyes for the vulnerability. If you don't have health security, I mean, your business is significantly hampered. So I won't mention any, but I could think of at least 10 Danish large companies that have shown support and worked with NGOs locally or worked with Danish NGOs. So some of these new partnerships, I think, has a huge potential. Thinking out of the box, doing stuff in a new way.
Yep.
Technology, as I also mentioned, has come a long way.
And now the time is running fast here, but perhaps I could ask, but come with the closing question. What would be your focus if you were the one to build up the ideal partnership between the researchers and also private sector companies and NGOs? What would be kind of the top 1, 2, 3 challenges that we need to address in the foreseeable future?
Wow.
Yeah. Just on top of your mind.
Yeah, I think some of the, sounds boring, but some of the classical, we have to build institutions. You know, we have to build long-term institutional partnerships. We have to build more holistic institutional capacity. We do have lots and lots of research and lots of NGOs and so on who are focusing on, you know, very specific, nerdy, interesting, whatever type of technology advancements or research. From a broad development agenda perspective, there are emerging super interesting private government or government institutions, also some of the old, I'm sure, but I see an emergence of flexible, ambitious, interesting new institutions across Africa for training, education, research, and so on. And I think we should join forces and build capacity of institutions for the long term, because I see, you know, then also large Danish companies come in with new technology training programs. And then we see, I think it's a lot about building institutions. Some that are there in times of trouble, and some who are there who can, I don't know, support human resource capacity development day in, day out. Not quick fixes, silver bullets, but boring long-term institutional capacity. I mean, I sit at an institution that's whatever, 500 years old. I don't say it's in any way ideal, but it has a history and it has a robustness, and it's not age, but the fact that there's an institution that carries that responsibility, not small niche players, but more holistic, strong institutions. But they can certainly, and I see a lot of the modern institutions so interested in working with NGOs, private sector, doing new ways of research. So it may not be the 500-year-old institutions, but some of the more recent upcoming institutions, but not programs, but institutions.
Thank you for that point. I think we're about to close, but I mean, if you briefly just could share some of the institutions that you're talking about, or the initiatives, not to highlight one bit more than the other, but just for, I think for inspiration, because for surely we buy into the whole premise that we need to work across We need to tie the networks and resources across institutions and build up that long-term capacity. So just for closing here today's talk, just for inspiration, feel free.
So I won't name them, but okay. I have for some time worked with an institution in northern Ghana. It's a university. It's super innovative. It's there for the long term. It's good at managing international stakeholders. They're in the driving seat. They're building infrastructure. They're pedagogic, much more advanced. Some of the older institutions, they work on internships, external thesis projects. They're fully integrated in the local community. I work with a broad-speaking tourist and tourist hospitality institution, some other place in East Africa, and they are the same, working closely with the private sector, managing international donors, applied research, problem-based, but strong, solid research. So they're not in bed with one particular international donor or one specific government department. They have a broader remit of stakeholders whom they manage well, and they're there for the long term, not the flavor of the month, but they're going to be there for 100 years.
Okay. Professor Flemming Konradsen, thank you so much for your time here today. I think we can all give you an applause around our small screens here and look forward for the upcoming weekend. Again, here from Access to Innovation, honored having you on board, and thank you for the insights that for sure we can bring onto our continued work. And of course, the premise of working across and working together also for the long-term focus is fully in line with our focus.
Yes, and thank you for the invitation.
We will, of course, continue here with the Access to Innovation talks. Next coming edition will be the 11th of June, where we invited Jesper Drescher, talking about also the investment climate and some of the opportunities that he's seeing growing at the African and especially East African continent. So from here, I'll be looking forward to seeing all of you again. And feel free to reach out if you want to engage further in our partnerships and initiative. Just for the part of it, I'm traveling next week to build up our closer relations, and especially with a focus on our long-term strategic focus with our partners in the South. So should there be anyone who needs a contact or network also in the Tanzania, Uganda, Kenya, please feel free to reach out. And if not, I'll hope to see you soon in about a month's time. Thank you so much for now.
Bye.
Thank you. Bye.